Welcome to today's presentation on launching 80% in every community across California. I'm Dr. Dorado Brooks with the American Cancer Society's National Office in Atlanta, and I will be sharing this presentation with my colleague June Hunter, who works in your part of the country. The objectives for today's talk are, one, to provide a snapshot of California's current colorectal cancer incidence, mortality, and screening data. Two, I'll talk briefly about colorectal cancer screening guidelines and testing options. And then three, talk about how we're going to move ahead and try to help every community in California achieve an 80% screening rate. So first, I want to talk a little bit about the success that we achieved in the initiative that recently ended, that being the 80% by 2018 initiative. We saw some tremendous improvement in a number of sectors. Colorectal cancer screening rates within the community health center environment improved by 40% during the 5 years of the 80 by 2018 campaign. And recognizing how challenging colorectal cancer screening is in many health centers, it is particularly impressive to see that sort of rise over, and that's nationwide, over this relatively short period of time. When we look at broader nationwide data accounting for all populations, we saw, based on CDC information, that we went from 65.2 to 67.3% in 2016. We are still awaiting 2018 data to know where we actually ended up, and indications are from the Centers for Disease Control that there has been continued improvement. We hope to have those numbers by the end of the summer or early fall. But at any rate, this what looks like a relatively small rise actually means that more than 5 million additional people were screened between 2012 and 2016. And again, we're anticipating an even greater rise. But unfortunately, a 67% screening rate means that still 1 out of every 3 people who should be screened are not up to date with screening. So it's important that we continue our efforts even in communities where we've seen significant progress, and we redouble our efforts in those places where we haven't seen the same level of progress. So let's talk about California and where California stands right now. With regard to colorectal cancer in California, it's the 4th most commonly diagnosed cancer, and it's expected that more than 15,000 Californians are going to receive a diagnosis of colon or rectal cancer this year, and more than 5,300 Californians are going to die of this disease, making it the 2nd leading cause of cancer death. If you look at trends in recent years, you can see that between from the early 90s to 2016, there has been a very steady downward trend in colon and rectal cancer mortality across California. And this data is broken down by race and ethnicity. The red line at the top is the African American population. It's been known for many years that non-Hispanic blacks had a much higher likelihood of dying from colorectal cancer. Unfortunately, that remains the case, but you can see that their line is trending downward, as are the lines for essentially all other racial and ethnic groups in the state. This is rectal cancer, colon and rectal cancer incidence within California. And again, while incidence rates have traditionally been much higher among Black population, you can see that over the last decade, there actually has been a strikingly greater downward trend, and consequently, their rates are getting closer to that of the non-Hispanic white and Hispanic and Asian population. So we are seeing significant progress in this disease, and much of that progress relates to screening and the outcomes of screening. Now, what we also know, however, is that where you live has a tremendous impact on whether or not you continue to live, and it has a tremendous impact on your likelihood of being diagnosed with and dying from colorectal cancer and many other diseases. The darker areas in these slides. On the left are incidence data. So darker areas have higher levels of incidence, and you can see the parts of California that have the highest, and also those parts that have the lowest, the lighter areas. And then on the right, the blue-green graph, again, darker is higher rates, and you see the darker areas of colorectal cancer death for the most part coincide with those areas of high incidence, although not entirely. So there are some places where the incidence rates are lower, but death rates are still high. And if you look at this and overlay it with access to health care, health insurance, poverty rates, oftentimes you will find that lower income, lower socioeconomic status areas are those that end up having significantly higher mortality, even if their incidence rates are not quite as high. If you look at the stage at the time of diagnosis by race and ethnicity, you also see some interesting things. We all know that finding disease in the earliest stages means we have significantly better outcomes, in particular with colorectal cancer. If the disease is found at stage, at a localized stage, 9 out of 10 of those folks are going to be alive 5 years later. So 5-year survival is 90% for individuals diagnosed with a localized colorectal cancer. As you can see, the white, African American, and Asian Pacific Islander population in California all have similar rates of early stage diagnosis, and that being 39%. But that means that even among those populations, 6 out of 10 people are diagnosed with more advanced disease. Rates of early stage diagnosis are even lower in the Hispanic and the Native American population. And then if you look at distant stage disease, remember, as I said, early stage disease, 90% 5-year survival. Distant stage disease, survival drops to 14% over 5 years. And African Americans and Native Americans have significantly higher rates of distant stage disease. Therefore, it's not surprising that they have worse survival rates. Now, when we look at screening in California by race and ethnicity, there's actually pretty good news when you look at the white and the black population. And as a matter of fact, both black and white women have come very close to achieving that 80% screening rate that we're targeting for everyone. Of course, again, this varies by socioeconomic status, also varies by what part of the state in which individuals live, but still that's very positive. And you can see that the screening rate among black men, at least back in 2016, was actually a little higher than that among non-Hispanic white men. But rates of screening for the Hispanic and the Asian Pacific Islander population trail far below those rates for the black and white population in California. So when we talk about screening, what are current screening recommendations? The screening recommendations from the American Cancer Society were actually updated in 2018, so just a little over a year ago. Up to that point, every major medical organization that published screening guidelines recommended that screening began at age 50 for all average risk individuals. However, since May of 2018, the American Cancer Society has actually recommended screening for all average risk people beginning at age 45. And this is because there have been significant changes in the epidemiology of the disease. So the recommendation is that screening for average risk individuals be done routinely between ages 45 and 75. And then for the age group 76 to 85, the recommendation should be individualized. That is, the clinician should look at the patient's overall health status, also look at their screening history. If this is someone who has been screened regularly since age 45 or 50 and never had any abnormalities found, then it is reasonable to consider curtailing screening. Or if someone has health issues that are likely to significantly limit their lifespan, screening may do more harm than good. So that the decision to screen between 76 and 85 needs to be individualized based on patient factors and discussion with the patient. From age 86 on, there is good evidence that we are much more likely to do harm than do good through screening. So screening is not recommended for this age group. Um, with regard to which screening test to use, we'll go into more detail later, but the primary thing to keep in mind is not every patient is interested in or willing to undergo colonoscopy, and not every patient has access to colonoscopy. There tends to be a real strong focus on colonoscopy in much of the U.S. healthcare system, and clinicians oftentimes favor colonoscopy to the exclusion of other screening tests. The reality is that colonoscopy is a good screening test, but there are a number of other tests that are recommended by both the American Cancer Society and the U.S. Preventive Services Task Force. Patients should be made aware that there are test options and given the choice to choose between, at a minimum, a colonoscopy, or what's referred to as a visual exam, an exam that looks inside of the colon, versus a stool test. And again, there are a variety of different stool tests. So every patient should be made aware that there are options for screening and allowed to make a choice about which screening approach to use based on their personal preferences and their what's available to them. Why did the American Cancer Society change their recommendation to begin screening the average risk population at 45? It's because of the data you see on the screen in front of you. As I showed you earlier and talked about, we've seen a very steady fall in colorectal cancer incidence and mortality going back for more than 30 years. That's illustrated on the left. And that's colorectal cancer incidence in men and women over the age of 50. However, in the population aged 20 to 49, during that same period of time, we have seen a steady rise. And as a matter of fact, since 1994, there's been a 51% increase in colorectal cancer incidence among individuals between ages 20 and 49. So the population that to this point has not been recommended to be screened. In California, we also have seen a very significant increase, particularly in the incidence. The mortality increase has been fairly small in this younger age group, but you can see that during that same period of time, from the late or mid to late 80s to the more recent period, there's been a steady uptick in the incidence rate of colorectal cancer among individuals between ages 20 and 49. So this is the data that led the American Cancer Society to begin to look at the feasibility and the efficacy of screening in this younger population. And there is a great deal of additional data, including modeling studies, that indicate that screening in the 45 to 49-year-old population will help curtail some of this increase that we're seeing. Consequently, the American Cancer Society now recommends that all average risk individuals begin screening at age 45. That also implies that you need to know who is at average risk and who may be at increased risk within your population. So you need to be doing a good risk assessment, in particular focusing on family history and individuals who have a family history of colorectal cancer or a family history of adenomatous polyps, particularly any first degree relative, are at even higher risk, and in most instances are going to need to start screening earlier, possibly at age 40, maybe even earlier than that, depending on their overall risk profile. So it's important to do an appropriate risk assessment before making screening recommendations. Now, what kind of strategies do we have to recommend to increase screening? There are a number of different approaches that can be used in the primary care environment to boost colorectal cancer screening. The thing that we do know is that doing one thing helps a little, doing multiple things, that is multi-component interventions, actually helps boost screening rates significantly more. This chart is from the Community Preventive Services Task Force, which is a government-funded organization that looks at evidence related to preventive health care. And you can see that they've looked at a variety of different interventions, client reminders, small media, one-on-one education. They've also looked at intervention strategies for practices for how you deliver services, as well as provider-oriented strategies. And they have summarized those that have evidence that support their value in increasing different kinds of cancer screening. Cervical cancer screening has actually been studied to the greatest level of detail, and you see more indications for cervical cancer screening. But there are a number of things that have been proven for colorectal cancer screening, and there are recent studies that are actually not reflected in this table that indicate that most of these interventions have some value for boosting colorectal cancer screening. The American Cancer Society and the National Colorectal Cancer Roundtable have created a number of different tools and resources, including a guide for primary care practices that summarizes the evidence and provides step-by-step guidance on how to implement many of these interventions within your practice.